Dear colleagues, welcome to this ESU Online event, which is focusing on some selected highlights from the recent extremely successful ESU meeting 2021. My name is Alberto Briganti. I'm urologist from Milan, Italy, University Vita Salute. And today I have the honor and pleasure to moderate a series of young and key opinion leaders in the field who have been selected with me to share main highlights of some topics which have been dealt during the recent meeting. I have the pleasure indeed to share this event with Dr. Van den Berg from Utrecht, the Netherlands, Dr. Giorgio Gandaglia from Milan, Italy, and Dr. Isabel Heidegger from Innsbruck, Austria. What we will do is that we will have 3 presentations. Each of these will be of 15 minutes, and we will cover COVID-19 session highlights, prostate cancer highlights, and also we will go through a very interesting clinical case with discussion. It's now time for clinical case discussion, and it's my pleasure and honor today to introduce now Dr. Heidegger from Innsbruck, Austria, who will lead us into a very interesting case, and we will discuss the main features related to the case itself. So please, Isabel, the floor is yours.
So thank you, Professor Briganti, for the nice introduction and for the possibility to present a case in this session. So I'm going to present you the case of a 65-year-old man with no comorbidities, no regular medication, and no previous abdominal surgeries. Concerning his family history, he had an uncle who was diagnosed with metastatic prostate cancer with 57 years. And the patients had already 20 years ago a tumor-negative transrectal prostate biopsy due to a PSA from 2.9. So when the patient presented in September last year at our hospital, he had a total PSA of 6.2 with a free PSA of 12.8%. The PSA velocity was 3.36. The Phi index was 63. The PSA density 0.24. The prostate volume was 25 milliliter. The IPSS 7. And he brought an externally performed MRI, which showed the Pryds 2 lesion. Neither in the urine nor in the digital rectal examination, the patient had signs of prostatitis. So the first question to the panel is, do you repeat the biopsy in the patient if he had presented with these fractures?
Giorgio?
Yeah. Actually, in the face of a negative MRI and relatively low PSA levels, the only factor that would prompt me to repeat or to perform a new biopsy is the family history. But otherwise, I believe I would also consider monitoring the patient.
Roderick, would you concede prostate health index as an indication for repeat biopsy in negative MRI patients like this?
I would consider it, but not before I would consider the density, which is unfavorable. And that is for me an important factor to stratify patients with negative MRIs to filter out the 10% that is false negative.
Myself, I will certainly have talked to the patients, but I would have suggested in view of the family history mainly, and also in PSA density, to actually go for MRI, for prostate biopsy in spite of a negative MRI.
Mm-hmm. Yes, we also did this. We performed a transrectal prostate biopsy with 10 systematic biopsies. And interestingly, in our hospital, the MRI-guided biopsies performs the radiologist, and he decided to take 5 MRI-guided biopsies according to the T2 sequence, despite we had this Pryds 2 lesion. And indeed, the histology confirmed the eczema and focal cribriform adenocarcinoma of the prostate in 9 of 15 cores, with a tumor localization on the apex left and the right lobe. The Gleason pattern was 7A, grade group 2. So if we go to the guidelines, we have now an intermediate risk prostate cancer. And as next step, we had a look at the clinical staging. And if we go again into the guidelines, ESOU 2, which is our patient, does not obligatory have to undergo a staging. If we go to the guidelines, what we can do now, we have basically 3 options. We have active surveillance, radical prostatectomy, or radiotherapy plus short-term ADT. And now the second question to the panel, what do you personally recommend to our patient?
Roderick?
So it's important to apply a multi-variable approach. We should not look for one parameter deciding on whether he needs treatment, yes or no. And there are some issues here, of course, the cribriform growth, but also quite favorable parameters like an invisible lesion on the MRI, a low PSA. So it's not that bad for this patient. And regarding the cribriform growth, I think it's important to realize that since a few years it has been recommended by ISAB to report it in the pathology report, but I think that we're quite far off really appreciating what the therapeutic impact of that should be. And also the inter-observer differences between pathologists. So of course it should ring a bell, but I think it's, well, it should not be the only reason why the patient should undergo active therapy. So for me, active surveillance is still an option.
If these patients were extremely motivated for active surveillance, which kind of, very briefly, which kind of follow-up would apply to this specific patient? A more like tight assessment of these patients, or something which is in line with what you do for low-risk disease, for example?
So we tend to repeat MRI after 1 year, and there's no evidence for that, I know, but that's what we do. And for a patient that is really like in the twilight zone of treatment versus active surveillance, I sometimes tend to repeat it after 6 months. And I think especially for these patients where the MRI did not show any abnormalities, I think that's a good option. The second question is, well, should we repeat standard biopsies, yes or no? But for such a case, I think it's, well, there's no doubt about it that we should at some point repeat the biopsy.
Quick question to Giorgio, if I may, since I have the pleasure to have you all online. Is the cribriform pattern, according to your experience or knowledge, something which should take into account not to suggest or not to consider active surveillance or not? I mean, I think this, and would you usually perform second revision of biopsy done elsewhere as your recommendation?
Yeah, we typically do, and I believe the cribriform pattern should at least alert us regarding the possibility that this patient has an increased risk of nodal invasion and adverse pathology. One other issue is that he received, let's say, a relatively small number of cores outside the index lesion, which was actually a Chiras 2 lesion, and that could also represent a kind of suboptimal assessment at the time of diagnosis. So I think in this case, I may consider active surveillance, but I believe that at the end, this patient is likely to receive at some point early in his natural history an active therapy.
Thank you. Please, Isabel.
Yeah, we discussed the options with the patient, also including active surveillance, but the patient decided to undergo for a surgical approach. So we performed radical prostatectomy with lymphadenectomy and nerve sparing. So the histology again confirmed the cribriform pattern, the Gleason state 7A, PT2-3 with no lymph node infiltration, but however with perineal infiltration. So the next question, was lymphadenectomy really necessary in this patient?
I believe that this is a question for Giorgio, right?
Yeah.
Yeah, I should say that according to the characteristics, it looks, I mean, probably no, it wasn't necessary. And they removed quite a high number of nodes. So it was an anatomically defined, theoretically an anatomically defined and well-performed lymphadenectomy. And we know that it increases the risk of complications. And in this specific case, probably it was unneeded according to available models. Again, the presence of a cribriform pattern at prostate biopsy is probably the reason why he received it.
Let me add one thing on this, because there is a nice report on European Journal of Cancer by Theodor van der Kwaas group showing that those patients with cribriform patterns had higher risk of nodal invasion. We have not been able to confirm these findings in our series, so in Milan, I think this guy would have not received a lymph node dissection.
Mm-hmm. Okay, so the postoperative course of the patient was with postoperative without complications. On the MCG also showed no extravasation in the sistogram, and the first PSA was 0.01. The patient was continent and he had still no sexual activity, but PDA5 inhibitors are ongoing, and yeah, the patient is staying well. Thank you.
So thank you very much, Isabel. So I do have one question for you guys. What if these patients had PT2C disease and instead of having PN0 stage, he had instead 2 positive lymph nodes at extended lymph node dissection with local disease stage, which is something that can happen in up to 12 to 15% of men with node positive disease. Roderick, node positive PT2C disease with negative margins.
So in the old days, and that's what the guidelines tell us, I think ADT or ADT combined with radiation would have been the way to go. I think we have changed our treatment strategy here, because especially in the recurrent disease setting, that PSMA PET scan is performing really good. So I would be, well, quite happy to see what happens with this patient. If the PSA is 0, just wait and see. There's no evidence for it, but I think that classically we use that PN information to guide our extra treatment. And since we have that new PET scan around, I think we can, well, relax that and see what happens and do an early PSMA, and that should decide our follow-up treatment.
Well, Roderick, it seems that you are very in favor of use of PSMA PET in the recurrent setting, which is indeed what the guidelines suggest. One question for you, because I think that this is something which is very practical and that we see every day when we do secondary consultations. Patients who are recurring, like those with extracapsular extension, negative margin, negative node, Gleason 8, and then 1 year after surgery, they start having PSA increase. And then they are referred to nuclear medicine physicians. They do PSMA PET scan, which is negative. What is the meaning, the clinical meaning of a negative PSMA? Because I still believe that in many of these patients, as you were saying in another setting, we might undertreat patients if we don't apply, for example, salvage radiation therapy, a timely one, if we just wait the imaging to be positive. And I believe this is a risky message to give, just to have your view, guys.
I think in that recurrent situation, you should use your imaging to rule out distant disease. If there's no distant metastasis, you should still treat the prostatic fossa. So you should not use it by waiting until you see anything to treat, but to rule out the distant disease, and that improves the outcomes of your prostatic fossa radiation. I think what's even more difficult is the situation where you have one positive node and a positive margin, and then 2 years after that, PSA is starting to rise. Then you really don't have a clue.
What I think is the PSA doubling time is also important in these patients if you don't see anything. If there's a high doubling time, I would more for aggressive treatment instead of we have a low doubling time.
Yeah, that's as a general comment. I think we should incorporate our new imaging within our classical prediction models. We should not throw them overboard. We should combine the PSMA imaging with doubling time, with the interval since treatment, with the Gleason score. That's the way to go.
I think that you say that, or you raise a very important point, the importance of combining different modalities, different data, different information to give a multivariable assessment of these patients. Imaging alone is not enough, PSA alone is not enough, but it's a combination of different tools. And one thing which I would like just to have your opinion about is the increasing use of multiparametric MRI for local recurrence after surgery. Is this something that you are using to rule out or rule in local recurrence, since we know that PET-CT might miss local recurrence? Are you doing this in combination with PSMA PET, or this is something that you do in highly selected patients?
We do it in highly selected patients when we aim to perform a HDR brachytherapy. Then we do it.
Yeah.
And we biopsy also the lesion before.
Yeah, after radiation only, but not after surgery.
Yeah, we have a protocol where we actually are prospectively performing this imaging technique in the recurrence setting. And I agree with the comment related to the fact that the negative PSMA is an excellent news for the patient, but still should not stop the delivery of a timely treatment.
Excellent. And I believe that the data suggests also, as you were saying, that indeed a negative PSMA is also a sort of prognostic marker, since these patients might have prognostic information by the fact that they might have recurrence, which is not picked up by the most sophisticated available imaging modalities nowadays available, which is a good prognostic factor indeed for the course of their disease. Very last question, which is related to also something which is related to COVID. Are you implementing your evaluation for these patients treated with surgery with a psycho-oncological assessment? This is something that we are implementing in Milan, and we are seeing more and more nice results of patients who are adhering more and more to our recommendations, being more satisfied with treatment delivery. Something I think to think about.
What we do is after diagnosis to have a shared decision moment. So patients discuss treatment with a urologist, but also always discuss treatment with a radiation oncologist. I think that's an important step. It improves treatment choice. It improves treatment satisfaction. And we have in my center 5 oncology nurses who are extremely important in, well, everything around the disease and, well, recognizing psycho-oncological issues.
Yeah, we offer every patient to speak to a psychologist, but honestly, not many patients use this option in Austria.
Excellent. Thank you very much. And I would sincerely like to thank you all for sharing with us this very nice and very interesting, at least for me, ESU Online event. And I would like to thank again Dr. Heidegger, Dr. Vanderberg, and Dr. Gandaglia for sharing with us their views, their talks, and for giving us some hints during our discussion. And I think on behalf of the entire panel of today, we would like to thank the ESOU for this nice invitation. And we hope that you all enjoyed presentations and discussion. And we hope to see you hopefully in person soon. Thank you again.